Dear friends, it's really a great honor and privilege for me to be here this morning and interacting with a very eminent cardiologist, not only of India but of the whole world. He is Professor M. Khalilullah. I don't think he needs an introduction here. He is a very eminent person. He is a pioneer or father figure of electrophysiology, and he is considered as the father of cardiology in today's world, in India at least. I know him for last almost 45 years when I was a student in a medical college. The only person I knew from Delhi were only two, Padmavati and Dr. Khalilullah. And I am very privileged that here I am interacting with him on a very important issue today. Dr. Khalilullah, I think there is a lot of data coming up that we see a lot of hypertrophy of the heart these days, and these people either have a hypertension or they have a hypertrophic cardiomyopathy. I'd like to have your viewpoint, sir. Lv hypertrophy, which we see because of hypertension, what is the comorbidity associated so that our students or our PGs can get a message of a hypertrophic cardiomyopathy and a hypertrophy produced by hypertension if not controlled meticulously? Your viewpoint, sir.
See, the ventricle has got two functions to perform. One is systolic contraction, so it can push the blood in the entire body to provide with the nutrition, oxygen, etc., etc. And the other function is diastole, it's relaxation. The ventricle hypertrophy interferes with the relaxation part of the heart, the diastolic function, and thereby the flow of blood coming to the heart is impeded, and there is a back pressure from there on to the proximal chamber of the heart, which is the atrium, and from there on to the lungs, the left side, on the right side into vena cava, etc. So when the hypertrophy takes place because of hypertension, it's gradual, and it's usually in the free wall. When the hypertrophy of the hypertrophic cardiomyopathy takes place, it is the hypertrophy in the septum. Now the septum gets hypertrophy apart from the free wall, and that causes obstruction to the outflow tract. So when the ventricle contracts, it finds that there is an obstruction in the outflow tract, and there is a gradient across the left ventricle cavity and the aorta, and the gradient is below the aortic valve, and it's a dynamic gradient. Like when the patient stands up, suddenly there is a decrease in the ventricle filling, and the gradient will increase. When the patient lies down, it will decrease. It can increase remarkably on exercise. So it's very important to know that people who have hypertrophic cardiomyopathy have a big risk of developing high gradient in the left ventricle because of exercise. On the other hand, a diastolic function is a phenomena which occurs all through. It can be aggravated by exercise because the cardiac output increases from the routine of 5 liters to about 8 or 9 or 10 liters, depending upon the vigorous exercise you're performing and the inflow of blood coming to the heart. And the heart is not able to relax, not able to diastole, not get into the good diastolic function. Then the back pressure can take place, and the pressure can rise on the left side of the heart. The left atrium starts getting dilated, and there is a pulmonary congestion. The patient gets dyspneic. Another very important factor which leads to a prolonged left ventricular hypertrophy is the atrial dilatation and arrhythmia, of which atrial fibrillation is a very, very important phenomena which is associated with high incidence stroke. A person who looks otherwise normal has hypertension and has left ventricular hypertrophy and has left ventricular dysfunction and left ventricular dilatation and stroke can suddenly get into disable situation and a thing will go. His career is totally at stake, his life at stake. So left ventricular hypertrophy should not be taken lightly, should be taken with all vigorous attention. And now we've been talking about the heart failure with preserved LV systolic dysfunction. Now that's a phenomena which is now gradually picking up. It is a different entity than the systolic dysfunction, requires a lot more attention and a little different line of therapy.
I think Professor Khalilullah has given and addressed a very complex issue in a very simplified manner for our proper understanding. Dr. Khalilullah said that LV hypertrophy is very, very important. We should not underestimate or ill understand or not understand the significance of LV hypertrophy. We must give a due respect to LV hypertrophy and he's very categoric. He said the hypertrophy of LV produced by hypertension can be a concentric LV hypertrophy or a generalized LV hypertrophy. It can be eccentric or it can be a concentric remodeling. It may not be a hypertrophy. It can be just a change which is remodeled. These are the three important things which can happen in the hypertension, and they do not affect the hemodynamics of a left ventricular outflow tract significantly usually. And he's very specific. He said the hypertrophy produced in a hypertrophic cardiomyopathy is usually asymmetric. There can be a mid-cavitary obstruction, there can be LV outflow tract obstruction. And he also said that all these patients are more vulnerable to go even to a sudden death. And he said very categorically that it is purely physical exercise dependent or a heart rate dependent. More the tachycardia, more the chances of having more obstruction in the LVOT or in the mid cavity, and more chances of sudden cardiac death, which we usually don't see with the hypertrophy of heart produced by the hypertension. And Dr. Khalilullah has mentioned very clearly that the hypertrophy should be prevented, regressed or reversed by all the methods possible to reduce the vulnerability for arrhythmias, to reduce the damage in the microvasculars, so that we are producing less damage to the heart or the vessels, so there is a less vulnerability for a heart attack. And he also said we can also reduce the prevalence of sudden cardiac death and atrial fibrillation. He is focusing on atrial fibrillation. He says all these patients who are hypertensive with a LV hypertrophy have increased pressures in the LV and diastole, as well as increased LA pressure, LA size increase, more atrial fibrillation, and he said that they are more vulnerable to get a stroke. So it's a multi-modality. I think it's multifactorial, and it has got a multi-morbidity. So this should be prevented, regressed and reversed aggressively if we really want to reduce the morbidity and mortality produced by uncontrolled hypertension. Professor Khalilullah, I think your words of wisdom are very well taken.
Thank
and
you.
I think the way you mentioned about the cardiomyopathy, which is a very different entity, and he used the word asymmetric, and he also said something on the aorta, that there can be a mid-systolic closure of the aortic valve, which may also affect. And he also said asymmetric hypertrophy, what we call as ASH. And he also says there can be some abnormality in the mitral valve, what we call as SAM, systolic anterior motion of the mitral leaflet. All these are obstructive or hemodynamic changes. The hemodynamic changes are very, very fast in a hypertrophic cardiomyopathy, and usually it is familial. It runs in families. Some sporadic cases are also known, and the treatment is very different. I think Professor Khalilullah's message is very clear that the hypertrophy of the heart should not be taken easily. Sir, my important question to you is that we do a lot of lifestyle modification, and we give some drugs like beta blockers or calcium channel blockers or ACE inhibitors or ARBs, and new drugs which are coming up now, AR and Bs. There are a lot of new drugs coming up now. Do you think that we really reverse the hypertrophy or regress the hypertrophy pharmacologically and non-pharmacological methods as compared to a hypertrophic cardiomyopathy? Sometimes they have to go for a radiofrequency ablation or a surgical myomectomy, or of course we use the drugs there
Septal
also.
ablation.
We'd like to have your viewpoint on that. Since you are a EP man of the world, we'd like to have your clear-cut delineation of hypertrophic heart because of hypertension and a hypertrophic heart because of hypertrophic cardiomyopathy, and the modality of our approach.
I think hypertrophy of the heart because of hypertension can be regressed by virtue of a lifestyle modification, cutting down salt intake, control of blood pressure, following yoga, meditation, and de-stressing yourself to cut down the surge of catecholamine in the body, and weight loss, etc. As well as by the whole range of pharmacological interventions available to us, right from beta blockers to ACE inhibitors, ARBs, or combinations. This all known to happen, and that's why I was describing in the earlier interview that we should keep a watch on this situation by doing an echocardiogram at least once in 6 months, get to know what is happening to the patient over a period of time. And but in patients who have hypertrophic cardiomyopathy, the situation is different. It could lead to diastolic dysfunction and dysfunctional congestive heart failure, or it can lead to arrhythmia and sudden cardiac death. And therefore, it has been now tried to regress septal hypertrophy by several techniques. One is in the cath lab, you can do alcohol septal ablation. You can do septal artery of the branch of the LAD and inject alcohol, block it up, thereby cause a controlled necrosis of septum and thereby decrease the outflow obstruction. The other thing is radiofrequency technique. But I think what has been now proved beyond doubt that long-term survival in patients who undergo myomectomy is possibly better than all these techniques. Still, the incidence of sudden cardiac death can or cannot be modified by all these techniques. Therefore, implantable cardiovascular defibrillator is indicated. Some of these patients in whom you have documented ventricular arrhythmias, lethal ventricular arrhythmias is very important.
Very well expressed by Professor Khalilullah that the treatment of hypertrophic cardiomyopathy is very, very different as compared to what we see in the hypertrophy with the hypertension. And he said that there has been some controversy initially of alcohol septal ablation and septal ablation by radiofrequency and a myomectomy. The data is more in favor of myomectomy to have the long-term benefit, because the short-term benefits are definitely seen with the septal ablation with the alcohol or with the radiofrequency. And he also said the number of these patients are more vulnerable to go into ventricular ectopics. So there is a post-ectopic gradient, and they are more vulnerable to a sudden death. So he used the word ICD. We have to use ICD, intracardiac device, as a defibrillator so that we prevent the death. A very important message. And there is a huge data. A lot of patients, because he said in his first statement that when these patients stand, the gradient becomes very high. And especially if there is an ectopic, maybe a ventricular ectopic, the gradient becomes further high. The chances of sudden death are very high. The only way you can prevent by a device, which I think Professor Khalilullah has very categorically mentioned. I think the message is very clear by Dr. Khalilullah's word of wisdom that hypertrophy should not be taken easy. And he also told that hypertrophy of the heart with the hypertrophic cardiomyopathy is very different. And the delineation was very clear in a very simple language. Even the treatment is very different, the prognosis is very different, and the diagnosis is also very different. Thank you very much, Professor Khalilullah.
Thank you.